Today's learning objectives, at the end of this webinar, you will be able to first describe 2 tools for increasing clarity of communication in teams. Secondly, apply select active listening strategies personally and as a team. And lastly, explain the value of a culture of curiosity and how to encourage it. Today's topic is Teamwork Part 1, Effective Team Communication, and this is led by Michelle Henne, who is a certified executive coach and leads specialist.
Thank you very much, Wen. Good morning, everybody. So as Wen mentioned, as always, we're following the Leads in a Caring Environment framework for our session today. And the topic of team communication falls mainly under the Engage Others domain and specifically under the capabilities of communicate effectively and build teams. So each session now, you're going to be meeting some of our new ACT physician leads. And this one is no different, and we're very pleased to have Dr. Shelley Hauk and Dr. Lori Montgomery helping with this session. And both are very experienced and knowledgeable and will bring a wealth of great stuff to our session this morning. So first up, generally speaking, a team is defined as any number of people associated together in work or activity. So to start us off in the chat, maybe you can just let us know who is your primary team. Maybe it's just you and your MOA, or maybe you have a full interdisciplinary team that's co-located or maybe not co-located, or maybe it's a call group. It could be completely different. So we just wanted to get a sense of who's your team. And then if you could also let us know how many teams are you actually part of in your work. So if you want to put that in the chat now, we'll take a look. It always takes a moment as people are typing. Here we go. So at the office, we have MOA and colleagues, or the OR team, acute care team, call group. So a few teams there for sure. Who took typing in grade 8? Fast ones. There we go. My main team is my section. I'm on about 5 teams. Yeah. Clinical and projects. Call group. Office team. Office staff. ACT team. That's team. Interdisciplinary. Okay, so yeah, so lots of team members located in the clinic. Yeah. Large interprofessional team, a dozen other teams. Wow. Office team, a big PCN team. Full interdisciplinary team at hospice, MOA. Yeah, lots of professionals working together there. PMH team, PCN, leadership office team, yeah. Co-located. Okay, so you can see there's quite a variety. Definitely a lot of people working in teams, and but all different flavors. So not surprising, and we'll keep that in mind as we go through the day today. All right. So we wanted to start off with just a quick video just to kind of set the stage. So we'll go through this first and then we'll talk about it after.
Das hier ist mein Sektor. Das hier ist das wichtigste Gerät des Küstenwächters. Das Gerät und das Gerät. Überlebensradar.
Mayday, mayday. Hello, can you hear us? Can you hear us? Can you... Over. We are sinking. We are sinking.
Hello? This is the German Coast Guard.
We are sinking. We're sinking.
What are you thinking about?
Okay. So a little amusement in the morning, but there's actually some valid discussion points in there. So what went wrong in that interaction? Pop that in the chat. What do you think? Where were some of the sticking points in there for communication? New employee with inexperience, yeah. And they were speaking a different language in an emergency situation. Radio malfunction, yeah, the tools weren't working great. Significant misunderstanding, yes, like very significant. No backup for the new guy. Yeah, Trevor. Handover very superficial. Yeah, like that was the fastest handover ever. And then he took off. Lack of skill and language barrier, good intentions but poor tools. Yes. Yeah. So basically, this poor guy, yes, yes, the person, well, they probably had a few things on their mind, but yes. So yeah, so he was basically given all that instruction and then left on his own. There was no opportunity for him to say, you know what, I'm not clear, or he wasn't asked, do you understand everything? That there was no loop there. It was just completely, here's the information. So that was an example of poor communication. We're going to talk about some tools that you can use to have great communication on the various teams that you're on. And, as always, communication and team communication is a huge topic, and we could spend days on it easily. So we're just going to dip in and, talk about a couple tools. It's by no means exhaustive in our time to date, but Melanie will pop into the chat a link to some of the past sessions that we've done. We've touched on some other communication strategies and tools in the past. And so if you're interested in learning more, you can always go back and look at some of those older sessions that we've done. There we are. All right. So to start up, our first one is huddles. And this is, of course, a very easy and effective tool for increasing communication on teams. And the regular use of huddles, or whatever you and your team want to call them, is so helpful to have an efficient day that flows smoothly. And the key, there's a couple of things to keep in mind. The first is that they're brief. So they need to be quick, usually 5 minutes, maybe 10 max. And they always occur at the same time and place. So everybody knows where to go, when to be there for the huddle, or they'll miss it. And then it's important to have all of the team members who are involved in the work that day included so that no one is left out. And then huddles usually include things like what's happening today. So sometimes there have been changes, some last minute change that's come up, and we can make sure everybody's notified. Maybe there's a patient coming in whose spouse has just passed away, and so everyone needs to be aware of that if they are greeting them or involved in their care, little things like that. What do we need to know today? What's our backup plan? So maybe what we need to know is that, Susan has an appointment in the middle of the day. She's going to have to leave for an hour, but if traffic's bad, she might actually be gone for longer. What's our backup plan? How are we going to fill in for her while she's gone? And even if she's gone longer than intended, who needs support today? Maybe someone's feeling a little off, a little under the weather, and they just need a little extra support. How will we manage that? And then at the end of it, very quickly, just summarize what are our actions then, and who needs to know, and how are we going to do that? And then sometimes huddles happen in an impromptu way. Sometimes you need a very quick huddle in the hallway about a particular, maybe it's an incident that's occurred or something that has changed. And this would be a smaller number of team members. And maybe it's related to something that there's a fair amount of information about. So consider using SBAR in these situations. And so if you haven't heard of SBAR before, it's a communication technique that was first developed in the military, specifically for nuclear submarines. And then it was used in aviation, and then later on, it's been used in healthcare quite extensively. And it stands for Situation, Background, Assessment, and Recommendation. And some people actually now call it ISBAR, where you make sure that you introduce yourself first. So depending on the situation you're in, you may or may not need to introduce yourself. So here's an example of what it could look like. So our physician says for her situation, do you have 2 minutes? I need to talk to you about Mary Smith. For background, she's 3 weeks postpartum after a long, complicated labor, culminating in a C-section. She's home with support, and both she and the baby are physically well. Her assessment, I saw her yesterday, and she seemed a bit flat to me. When I asked her how she was doing with everything, she broke down and said she can't stop crying. She also said she has no appetite and no energy. I'm concerned something more is going on with her. She told me she has had episodes of depression in the past. And then her recommendation, I've ordered some tests to rule out a physical cause, but I think she needs to get started with psychiatric support sooner than later. Can you see her this week? So again, a very quick and efficient way to share the important information. Now that slide depicted the two colleagues seeing each other in person, which we know is very unlikely, unrealistic. So media is typically going to be used, and in most cases, email is a very common one. So just a couple tips about how to use email effectively to get answers when you want them, to get the intended outcomes when you're sending them. So first of all, send a clear subject line. So make it obvious from the first glance what is expected of the receiver. Is this information only? Are you asking for a response from them? Are you asking them to take action of some kind? And then put in your personal greeting, because it's about communicating the information, but it's also about building relationship. That's an important aspect of team and building trust. So take a moment to just put in a little personal line at the opening. And sometimes like I'll often put in the body of the email and then go back and add the greeting line, just so that I'm making sure that that has that human touch at the end. And then, of course, you're filling in what is needed and by when. And you're going to want to use anything that's going to catch the eye, like highlighting or changing fonts for the key aspects of that email. So go through and decide what is critical in here. What are the maybe 3 things that I want to make sure this person sees if they're an email skimmer, which a lot of us are. So if they're just skimming, I'm going to highlight and make it easy for them to see the things that I want to make sure they don't miss. And then you can give the details. SBAR is a great tool to use in emails. Again, it helps keep them efficient and brief. And then use bullet points wherever possible. That's easier for the eye to skim than narrative. And then, yeah, highlight the important points. And then when you sign off, say something again that may help to build that connection and community. So here they've said, please know that your tireless efforts in this work are valued and appreciated. So a little opportunity to build team. So I'm going to go to our panel now, to Shelley and Lori. So I'm going to say it again. What are you thinking about this stuff? We can start with Lori.
Sure, thanks. Well, I mean, as you always say, Michelle, we could spend about, 4 days digging into the various bits of this topic. But one of the things that kind of comes up for me as I'm thinking about strategies of communication and the kinds of teams and what you're choosing, one of the things that kind of pops out is who is the leader of the team and how does that affect what your communication looks like. So we sometimes assume that it's always going to be the physician that's the leader of the team. And that's not always the case. Sometimes the people around us assume that it's the physician who's the leader of the team, and that may not be the case. Sometimes it's really straightforward. You're the owner of the clinic, all these people work for you, that you're the leader of the team. But that doesn't necessarily mean that in every conversation you want to be taking the lead, and you might actually prefer to sort of assign somebody else to take the lead in those kind of conversations. But it's worth having some purposeful thinking about who is taking the lead. I work in an interprofessional team, which is different from a multidisciplinary team. We might have to have a whole other session to talk about that. But in an interprofessional team where, I work together with the same group of people all the time, leadership can be a bit more fluid in that team. And I will say actually quite a lot of the time it doesn't make sense for particular patients for me necessarily to be the one taking the lead. So we kind of fall into some accidental patterns of how we communicate sometimes, but it's worth stepping back and actually thinking about, in this situation with this team, in this patient situation, who does it make sense to take the lead here?
Yeah. Yeah, thanks, Lori. That is great. That shared leadership, I think, works really well on teams of these highly skilled professionals, particularly. And Shelley.
Hi, thanks for asking me to join. I think that that there's a few different things that come to mind when I think about team communication and leadership. I've been on many teams, some of them clinical and some of them more administrative. So there's obviously different types of teams, as Lori was mentioning. But what I think when I look back, the teams that I found most effective were always teams in which there was a willingness or an openness for uh, different ideas and sometimes discordant ideas to come forward, which is sometimes uncomfortable for people. But it often is the leader, whoever that happens to be, whether you are the team member or the leader can change, but often the leader of that team or that discussion, people take their cues from them. And either they may explicitly set the stage for that, or they may implicitly make the environment such that people do contribute or they don't contribute, and it's a very different discussion that can occur. I think the leaders that are have difficulty with this. Sometimes it's from their own insecurity, perhaps. Sometimes it's from their own arrogance, perhaps. It can be a wide variety of things. And of course, it does take it takes the team players and the leader to make the team. It's not just one or the other. But sometimes there can be a unexpressed sort of feeling within the group that could be really good, or it could be maybe not so good. And sometimes, as Lori was mentioning, it's worthwhile stepping back and saying, why is this working? Or maybe why is this not working? And seeing if there's other tools that can help.
Yeah. Yeah, great comments. And you're kind of describing psychological safety, which has definitely been shown to be a really important factor in high functioning teams. So yes, we'll talk about that a tiny bit in a moment. So great foreshadowing. All right, so getting back into our tools and resources. When you look at this, what do you quote unquote hear? Do you think it's fine? Do you believe her words? Maybe, maybe not. Probably not, because when words and nonverbal messages are conflicting, as humans, our brains tend to believe the nonverbal. So according to psychologist Albert Marubian, there are 3 elements that account for our perception of a person's message, and specifically this pertains to feelings and attitude. So 7% is in the words spoken, 38% is through the tone of voice, and 55% is through the facial expression and body language. So really, we are listening with our ears, but also with our eyes and guts. And especially if we're consciously deep listening, we're using all of these senses, not just listening. So then there's texting. A lot of missing cues here. We're not getting that tone of voice or seeing the body language. So again, what do you think? Is it really fine? What about now? Does it seem more fine now? And we often think of emojis as kind of silly, but actually they were designed to fill that gap between, the words on the screen and the body language or tone of voice that's implied. So again, I don't really have hard evidence, but I think emojis have probably saved a few marriages because they really can help to avoid misunderstandings from interpretation of what's on the screen. So Shelley, you have a story to share with us. I'll hand it over to you.
Sure. I think I'm sort of preaching to the choir in that all physicians really have that ability for deep listening, and we use it, I think, all the time with our patients, or many of us do. And it's kind of that what I call the spidey sense of an encounter. And I'm just going to share one example that I have. I know that all of you would have many other ones to share, but I recall one of my patients in for a well baby check. Her baby's maybe 3 months old. I've seen them a couple times before. She's my long-term patient. I know her. This is her first baby. And, baby's growing and everything seems good and there seems to be good interaction. But there was something, and I don't know what the something was that was off. I couldn't even tell you what that was if I look back. But I recall that I said something that I've don't normally say. In fact, I've never said to any other patient. And she was just kind of getting the baby back in the whatever outfit the child had. I can't recall. And I just said, when my daughter was 3 months old, she had colic. And even though I loved her so much, there were so many times I just wanted to throw her out the window. And I she burst into tears. That's kind of was the tipping point. There was something, and that was it. And she was actually hiding a lot of that very, very well. So I think that we sort of put our spidey senses on when we're in patient encounters, and we sometimes do that without even realizing it. What I realized is that it takes a lot of energy to have those kind of deep listening skills always turned on. And I think I also got very good at turning off my spidey senses, in that when I'm in with co-workers or colleagues or administrative meetings or staff meetings, I'm aware that sometimes I was there physically, but not always there mentally, because I really wasn't bringing my deep listening skills. I wasn't bringing that piece to the meeting, and that was probably a disservice to the other people there. So I guess I would challenge people to say, do we know when to turn those on? Even in those kind of team encounters that maybe aren't with a patient or are in a different venue, and we all have that skill set. Are we using it to the full extent that we can to make sure our team interactions actually end up being as positive as they can be?
Yeah, that's a great point, Shelley. That deep listening can be kind of exhausting, and I get it. When you've been doing it all day with patients, it's hard to turn it on with a team as well. But again, recognizing when it's important to do so, and yeah, and it is you can be conscious about it, turning it on and off. All right. So, oops, here we go. We're going to talk a little bit about another tool now called closing the loop listening. And you've heard this before. It's very common in situations like this. So Bethany, please give the patient 2 milligrams of morphine for pain relief. 2 milligrams of morphine, correct? Yes, that's correct. Okay, I'll go there now and give her 2 milligrams of morphine. So again, for safety reasons, that closed loop listening is important, but it can also be used in general conversation. So remember back to our situation where our physician has just given her SBAR report. And now she looks over, she's picking up some cues that perhaps the receiver is not fully receiving. And so she can choose to use that feedback loop here and just say, you can see Mrs. Smith this week then, is that correct? And then what she gets, a response that provides better clarity, that she was distracted and she actually can't see her, but she knows her colleague can, so she's going to pass the request on. So she's just taken that moment to get that loop around to make sure that they're both on the same page before they move on. Again, just a way to keep safety in mind and keep things from falling through the cracks like this patient may have. But asking questions is likely easy between physician colleagues, but not all team members will feel comfortable asking questions of those that they perceive as being, higher in the hierarchy than they are. And so this is really dependent on the team's culture, whether or not they feel comfortable with that. And that speaks to what we were getting at earlier, this psychological safety. And we've talked about this several times in our sessions because it is such an important aspect of working in teams. It is actually the key to high functioning, effective teams, whether this exists or not. And according to the expert in this area, Amy Edmondson, psychological safety is part of a team's culture when team members believe they won't be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes, meaning they feel safe taking a risk, like asking a physician a clarifying question, even if that challenges how things are done. So Edmondson and several others have published studies that show how environments that encourage questions and dialogue contribute to a lot of things like better team learning overall, innovation. People are willing to try new things because if you try something new, you're probably going to fail before you get it right. And they're just more effective overall. And this is particularly relevant to healthcare teams or any other team that really is working in high stakes. So encouraging questions within healthcare teams allows for better clarification before action is taken. It prevents errors of all kinds, and it promotes collaborative problem solving. So as a leader, whether it's a formal or informal leader, and then team members as well, everyone on the team is responsible for creating the culture. So everyone can model this and encourage the development of this psychological safety by modeling openness. So asking questions like, what could go wrong here before we do something new or try something? You can build trust by showing gratitude for questions when they do come up. When someone is brave and takes a chance and challenges something or asks a question, thank them for bringing it up, even if it's hard. And then creating regular opportunities for reflective questioning. So things like, what other questions do you have? And don't hesitate to ask if something else comes up. So we do have a tool that we'll send out in our summary email at the end. And it's just an optional tool that looks at psychological safety. So if you're interested in that, you might want to go through it and see where you fall, where you might need to do some work. And Lori will give you the final word here.
Okay. Well, not really final, because then we're going to go into the breakout rooms.
Well, yeah, it's not final, but yes,
then everybody else will have the final. Yeah, I think it's interesting. I like that you brought up the CMPA checklist there, because the CMPA has a whole toolkit for working in teams, multidisciplinary or interprofessional teams. And it kind of made me think about, I love what Shelley was saying about the fact that we learn these deep listening skills and we practice these things with patients, and then we don't necessarily transfer those skills out to our colleagues. We spend all this time in our training, we do simulations, we take entire courses in communication with patients, and then we don't put the same sort of purposeful attention into communicating with our teams. So CMPA actually has a checklist for communicating with teams as well. So what they recommend is, if you've got a fairly stable team that you're working with fairly often, that you actually take some time at the beginning when, or now, if it's the first time that it occurs to you and you've been working with them for years, to actually sit down and say, okay, who are all of these people? What are their scopes of practice? So what's their legal scope of practice? What have we decided is going to be their scope of practice in this situation? Who are they? What do they like to do? What do they not like to do? What would they maybe like to do more of if you could provide them with some mentorship, and really be deliberate about deciding who's doing what, in what situations, how do we want to communicate as a team, and that it's worth the investment of just one purposeful communication meeting to just talk about how you're going to do that with your team. The other day we were talking about the fact that we kind of assume that some of these things are generational, like, the millennials want a text and the older people want a phone call. And it's not necessarily generationally based. It may just be some people on your team actually just prefer to get a text before you call them, before you talk to them, or some people are really nervous in an in-person situation and they need some time to reflect and get back to you by email. So taking some time to actually talk to the team, figure out who they are, can guide you in terms of what strategies you're going to use.
Yeah, absolutely. And this is, I mean, teamwork, effective teams, they take the time, they do the work. They don't just magically happen. So yeah, there is a little bit of time to put in and then it reaps benefits. So yes. All right. We're going to move into breakouts now. So I'm going
And as part of our wrap up, there is another on December 10th and 11th, a PM and an AM offering session. So please do check on that if you're able to participate. And the topic is in Teamwork Part 2. We're going to be doing a deeper dive into the leadership styles. And coming soon, there will be a summary email.